ETS in 2022, suggested with class 1A of recommendation endovascular laser for treatment of great saphenous vein, small saphenous vein, and anterior accessory saphenous vein. Laser shows high selectivity for varicose vein due to the presence of chromophore in the target tissue. The element that most affects this selectivity is the wavelength. The previous generation laser is predominantly absorbed by melanin, around under 1,000 nanometer laser by hemoglobin, and around over 1,000 nanometer by water. The 1940 nanometer laser has an absorption coefficient of water more than 4 times higher than second generation laser and about 2,000 times higher than previous generation laser. The water is more concentrated than other chromophore in and around the target vein. So the water for the new generation laser allows the possibility to treat the vein using a low power and low lead. This is the laser that we are using now, 9040 nanometer NeoVu laser. Some technical notes: the power from 1 to 6 watt does not cause laser fiber carbonization, reporting less pain during the procedure. This other device has evolved recently. The first generation laser was bare with frontal emission, with the possibility to sharing of the fiber tip, the high risk of venous perforation, nerve damage, pain, ecchymosis, and less effective treatment. After the jagged tip, always with the frontal emission, and then second generation laser with a good idea to switch the radial emission from the blood to the vein wall. And now the cylindrical shape with a large area of emission as the Corona Infinite ring, the ring that we are using now, with a fully fused tip, a large area of radial emission, about 3-4 millimeters. This led a more uniform radiation, lower irradiance, and lower peak of temperature. But how do these new devices work together? I would like to introduce you the latest study that we are publishing, and we analyzed 93 patients to 100 procedures carried out in the first quarter of 2021. The primary endpoint was occlusion rate for efficacy, percepted pain for safety, and the secondary point was lead for efficacy and improvement in SIP classification for safety. The demographic data is in line with the epidemiologic data of varicose vein. We decided to exclude the SIP1 patient. We treated 69 greater saphenous vein, 19 anterior and accessory saphenous vein, 10 small saphenous vein. In 2 cases, both greater saphenous vein and anterior accessory saphenous vein. The average diameter was 7 millimeters. The average diameter of the vein 2 centimeters below the junction was 7 millimeters, and the main length was around 28 centimeters. The results after surgery that was carried out only in outpatient treatment and under local anesthesia was good. As you can see here, we worked with a very low watt and very low lead. The follow-up was made with duplex ultrasound, and after 30 days, we had 100% of occlusion rate, and after 2 years of follow-up, 96% of occlusion rate. The 4 cases of recanalization was attributable to our initial experience with this new device.